everyone, I am myself Dr. Rajesh Gubba. I am the general medicine educator. So in this session, I'll be discussing a very important topic in the cardiology, that is the arterial, right? That is the arterial pulse. So first, you need to know the basic definition of the arterial pulse. So arterial pulse, it is a waveform, right? So a pulse wave is a waveform, right? A pulse wave is a waveform that is felt by the finger, right? That is felt by the finger, which is produced by the cardiac systole. Right? So that is what is the arterial pulse. Now you need to know that what are all the various vessels at which you can feel for this particular arterial pulse. So the time at which the pulse wave arrives after the cardiac systole is, it can be felt in the carotid, brachial, femoral and as well as the radial artery. So this particular arterial pulse, it is being felt after 30 milliseconds after cardiac systole, right? It is being felt in the brachial artery after 60 milliseconds, whereas over the femoral artery, it is being felt after 75 milliseconds, and over the radial artery, it is being felt after 80 milliseconds. Okay, so this is the time duration after which the pulse is being felt in all these vessels after the cardiac systole. Now, whenever you are examining an arterial pulse, what all the things you need to assess in the arterial pulse? So, the arterial pulse is assessed in the following way, that is rate, rhythm, volume, character, and you need to know whether the pulse is being felt in all the peripheral pulses or all the peripheral vessels or not, and you need to make out is there any presence of the radiofemoral delay, and you need to make out the condition of the vessel wall. So arterial pulse is assessed in the following way. Now first you take the various vessels, what are they used for? You take the radial pulse. See, radial pulse is felt to assess the rate and rhythm. Right? It is to assess the rate and as well as rhythm. Whereas the carotid pulse, it is being felt to assess the volume and character. Right? Volume and character. Whereas the brachial pulse is felt to record the blood pressure. Right? It is being felt to record the blood pressure. So this is about the various pulse, the various vessels which are being used for various parameter assessment of the arterial pulse. And if you take the normal pulse rate, normal pulse rate is 60 to 100 per minute. Right? Normal pulse rate is 60 to 100 per minute. And when do we use the word bradycardia? We use the word sinus bradycardia when the pulse rate is less than 60 per minute. Right? And when do we use the word sinus tachycardia? We use the word tachycardia when the pulse rate is more than 100 per minute. That is the point when we use the word tachycardia. Now you need to know what are the causes for bradycardia. So for an individual to develop bradycardia, there are physiological causes for bradycardia and as well as the pathological causes for bradycardia. So first of all, if you see the physiological causes for bradycardia, right, in athletes, see, in case of athletes, right, in athletes there will be increased vagal activity and that is the reason why there will be bradycardia, and the same thing is during sleep as well. So even during sleep there is reduced sympathetic activity and there will be increased parasympathetic activity, and that is the reason why there will be bradycardia. Then followed by that, what are the pathological causes for the development of bradycardia? Pathological causes for the development of bradycardia include number 1, hypothyroidism, which is a very important condition. So in hypothyroidism, the thyroid levels are reduced and thereby there will be negative chronotropicity that will result in bradycardia. Then the other conditions where you have bradycardia is in clinical scenarios like heart blocks, right, that is first degree, second degree or third degree AV block. Then there are certain drugs which will cause the bradycardia. So the drugs which will cause bradycardia include beta blockers, then the calcium channel blockers. Then we have, see, the examples of these calcium channel blockers include diltiazem and verapamil, and the other condition which will cause bradycardia is digoxin, because this particular digoxin will increase the AV nodal conduction time and thereby there will be decrease in the ventricular rate. Okay, so these are the drugs which will cause the bradycardia. Then followed by that we have obstructive jaundice. So in patients with the obstructive jaundice, there is increase in the bilirubin, and that increased bilirubin will go and get deposited within the SA node, and thereby the origin of the impulse from the SA node will be reduced, resulting in the bradycardia. Next, we have one clinical condition where there is abnormality within the SA node itself, and that clinical condition is called sick sinus syndrome. Right, that particular clinical condition is called sick sinus syndrome, where there is abnormality within the SA node itself, right? And the other condition where you have the presence of bradycardia is raised intracranial pressure. So in clinical scenarios of raised intracranial pressure, there will be activation of the Cushing reflex resulting in the bradycardia. Then in conditions like raised intraocular pressure, there will be pathological bradycardia, right? And finally, in patients with severe hypoxia, there will be bradycardia, and then in patients with hypothermia, right, you have the presence of bradycardia. So these are all the pathological causes where you have the presence of bradycardia. Now, after having discussed about the conditions, physiological and pathological conditions for bradycardia, let me discuss the conditions where you have the presence of the tachycardia. So, after having discussed about the conditions causing bradycardia, let me take up the conditions causing the tachycardia. So, tachycardia also, it could be either the physiological tachycardia or there can be a pathological tachycardia. So, if you take the causes for the physiological tachycardia, right, it is seen in case of infants and children. Right, infants and children. And apart from that, emotion and as well as exertion, these are also the conditions where the individual will have tachycardia. So, emotion and as well as the exertion. Right, so these are all the conditions where you will have the physiological causes where you have the tachycardia. Now, if you take the pathological causes, right, if you take the pathological causes for tachycardia, that includes the tachyarrhythmias and as well as the high output states. Now, what are the causes for the tachyarrhythmias, right? Which particular tachyarrhythmias will cause the tachycardia? That includes your supraventricular tachycardia and as well as the ventricular arrhythmias, that is ventricular tachycardia or ventricular fibrillation. So these are the tachyarrhythmias which will cause, these are the pathological causes for tachycardia. Then you take the high output states causing tachycardia. High output states causing tachycardia, that includes anemia, then thyrotoxicosis, next beriberi, right, then fever, next pregnancy, next presence of the AV fistula. So these are the high output states where the individual will have the tachycardia, and not only that, even in patients with pheochromocytoma. Okay, so these are the high output states where the individual will have the tachycardia. Now apart from that, we have few more pathological causes for tachycardia. In patients with the coronary artery disease, like in patients with acute anterior wall MI, can cause tachycardia. Then you take in patients with the cardiac failure, right, you take in patients with the cardiac failure, the individual can have tachycardia. Then in patients with hypovolemia and hypotension, can also cause the tachycardia. And apart from that, we also have some drugs causing tachycardia. So what are these particular drugs which will be causing tachycardia? That is mainly the thyroxine supplementation will make the individual to have increase in heart rate, right, and the adrenergic agents will cause tachycardia. Then followed by that, atropine supplementation can cause the tachycardia. So these are all the pathological causes for tachycardia. Now followed by that, we have one particular important clinical entity called the pulse deficit, which is also called the apex pulse deficit. Now what is the definition of this particular pulse deficit? It is the difference between the heart rate and the pulse rate. Right, it is the difference between the heart rate and as well as the pulse rate. That is what is called as the apex pulse deficit. And whenever there is a difference between the heart rate and as well as the pulse rate, you need to count the heart rate and as well as pulse rate for 1 full minute. Right, you need to count both of them for 1 full minute. Right, then what are the causes for the apex pulse deficit? Okay, first let me explain you this in detail. In a normal individual, right, in a normal individual, the heart rate will be equal to that of pulse rate. That means the apex pulse deficit in a normal individual is 0. Right, in a normal individual, the apex pulse deficit is 0. But there are certain clinical scenarios where the heart rate will be more than compared to that of pulse rate. What are those conditions? Those conditions include atrial fibrillation, right? Those conditions include the atrial fibrillation and then ventricular premature contractures. Okay, so these are the conditions where you have the presence of the apex pulse deficit. That means in these two conditions, the heart rate is more than compared to that of the pulse rate, and that is what is called as the apex pulse deficit. Now how will you differentiate between these two? Let me explain. So if you take the differences between ventricular premature contractures and as well as the atrial fibrillation, if you take the pulse deficit in case of the ventricular premature contractures, pulse deficit in case of ventricular premature contractures is less than 10 per minute. Whereas in atrial fibrillation, the pulse deficit is more than 10 per minute. Right, more than 10 per minute. And if you take the waves in the JVP, right, if you see the waves in the JVP, a wave in the JVP, it is present in case of ventricular premature contractures. But a wave in the JVP, it is absent in patients with the atrial fibrillation. That is very important. Now, what will be the fate of these waves on exertion? So, on exertion, ventricular premature contractures, they decreases or they disappear. Right, they decreases or they disappear. Whereas if you take atrial fibrillation, the apex pulse deficit will persist or even increase on exertion. Right, the apex pulse deficit will persist or increase on exertion. Whereas in ventricular premature contractures, the apex pulse deficit, or in fact the ventricular premature contractures itself, right, the ventricular premature contractures itself, they will decrease or disappear on exertion. Then you take the rhythm. See, in both of them, it is an irregular rhythm in the pulse, right? In both of these scenarios, it is an irregular rhythm in the pulse. But in case of the ventricular premature contracture, there will be presence of a short pause, right? There will be presence of a short pause followed by a long pause. Okay, so between the normal beat and as well as ventricular premature contracture, right, between the normal beat and ventricular premature contracture, you will have a short pause, and this is followed by, right, this is followed by a long pause. Following ventricular premature contracture. Right, after the ventricular premature contracture, there will be a long pause. But whereas between the normal beat and ventricular premature contracture, you will have only a short pause. Then you take in case of atrial fibrillation, pauses are variable and they are chaotic. Right, the pause, it is variable and chaotic. Okay, so that is what is the rhythm in case of the atrial fibrillation. Okay, so these are the differences between the ventricular premature contractures and atrial fibrillation. In both of them, you have the presence of apex pulse deficit, but it will be less than 10 in case of VPC, more than 10 in patients with the atrial fibrillation. Now, after having discussed about the rate, the next important thing in the pulse that we need to discuss is about the rhythm. So, the question is, irregular rhythm is seen in atrial fibrillation, ventricular bigeminy, paroxysmal atrial tachycardia, and as well as the atrial flutter. So, please remember, irregular rhythm, it is seen in patients with the atrial fibrillation. Now, let me discuss about the rhythm. See, if the individual has, right, if the individual has the regular beat, then that means the interval between the two beats, if it is regular, then we call it as regular rhythm. But if the interval, so one we call it as regular rhythm, and second, if you see, if the interval between the two beats, if it is irregular, then we call it as the irregular rhythm. Now, this irregular rhythm, it is again of two types, two subtypes. one we have regularly irregular rhythm, then next we have irregularly irregular rhythm. Right, one we have regularly irregular rhythm, the second what we have is irregularly irregular rhythm. So this is about the rhythm regularity and irregularity. Let me discuss what are the conditions where you will have regularly irregular rhythm. First of all, you have to understand what do you mean by the word regularly irregular rhythm. So that irregularity is appearing in the pulse, but that irregularity whichever is there in the pulse, it will occur in a regular fashion, right? It will occur in a regular fashion. That is what is called as regularly irregular rhythm. And where do you have this? You will have this in patients with the ventricular bigeminy and as well as the ventricular trigeminy. Right, so in ventricular bigeminy and as well as ventricular trigeminy, you have the presence of the irregular rhythm. And the other condition where you have the presence of the irregular rhythm is the atrial tachyarrhythmias. Right, atrial tachyarrhythmias with fixed AV block. Right, atrial tachyarrhythmias with fixed AV block. Now what are those atrial tachyarrhythmias with fixed AV block? That includes the atrial flutter, and as well as paroxysmal atrial tachycardia. Right, paroxysmal atrial tachycardia. So these are the two conditions where, these are the two atrial arrhythmias with fixed AV block, you have the presence of the regularly irregular rhythm. Next, if you see the conditions where you have irregularly irregular rhythm, see the conditions where you have irregularly irregular rhythm is in patients with the atrial or ventricular ectopics, right, in patients with atrial or the ventricular ectopics, and second, in patients with the atrial fibrillation, third, in patients with atrial tachyarrhythmias with varying AV block. With varying AV block. Okay, so that is about the irregularly irregular rhythm. So it seen in case of atrial or ventricular ectopics, atrial fibrillation, atrial tachyarrhythmias with varying AV block, right? And what are those atrial tachyarrhythmias? That includes paroxysmal atrial tachycardia and atrial flutter. Right, that includes the paroxysmal atrial tachycardia and as well as the atrial flutter. So these are the conditions where you have the presence of irregularly irregular rhythm. Now let me show you these particular ECGs. Now, so if you take this particular ECG rhythm, you take ventricular trigeminy. See what will happen in case of ventricular trigeminy? Every third beat is an irregular beat. So you can observe that here, this is one normal beat and this is second, that is a normal beat, and this is a third which is an abnormal beat. You can make out the QRS complex there, it is a bizarre or abnormal QRS complex. Then you have one normal beat, second normal beat, and third one is an abnormal beat, right? The third one is abnormal beat. So every third beat is an abnormal rhythm or an abnormal beat. So what is this rhythm? We consider it as regularly irregular rhythm. Right, regularly irregular rhythm. Then you take the another ECG of ventricular bigeminy. In ventricular bigeminy, you can make out this is a normal beat and this is an abnormal beat. This is a normal beat and this is an abnormal beat. So every second beat is an abnormal beat here. So this we call it as the ventricular bigeminy. So what did I tell you? You will have a short pause between the normal and as well as abnormal beat. You have the presence of a very short pause. Right, you have the presence of a very short pause. Whereas after an ectopic beat, you can make out that there is presence of a very long pause. Right, you can make out that there is presence of very long pause after an ectopic beat. Okay, so that is what will be the rhythm in patients with ventricular bigeminy and as well as ventricular trigeminy. Whereas you take this particular ECG of atrial fibrillation where you have an irregularly irregular rhythm. See, irregularly irregular rhythm, you have varying RR intervals. So the RR intervals, they don't maintain the regularity. So the ventricular beat, it appears at any point of time. They doesn't maintain any particular regularity. So irregularly irregular rhythm seen in patients with atrial fibrillation or irregularly irregular rhythm is seen in patients with atrial tachyarrhythmias with variable AV block, that is in paroxysmal atrial tachycardia and as well as the atrial flutter. Okay, next. Now, after having discussed about the rate and as well as rhythm, the next thing like what we need to discuss is about the volume. So if you take the pulse volume, it is assessed in the carotid artery. Right, pulse volume, it is assessed in the carotid artery. Right, but whenever you palpate the carotid artery, the pulse volume assessment, it becomes completely subjective. So one individual may feel it is a normal volume, the other individual may feel it is an increased volume. So in order to avoid this particular confusion, the pulse pressure, it gives an accurate measure of the pulse volume. Right, pulse pressure, it gives an accurate measure of the pulse volume. Okay, and how do we calculate this pulse pressure? It is the difference between systolic blood pressure minus diastolic blood pressure. This will be your pulse pressure. Systolic blood pressure minus diastolic blood pressure will be the pulse pressure. And if you see or if you observe the normal pulse volume, right? When do you consider that the individual has a normal pulse volume? That is when the pulse pressure if it is between 30 and 60 millimeters of mercury, right, that is between, if the pulse pressure is in between 30 and 60 millimeters of mercury, then the pulse volume is considered to be normal. But when the pulse pressure is less than 30 millimeters of mercury, right, when the pulse pressure is less than 30 millimeters of mercury, this we consider it as small or low pulse volume. Right, this we consider it as small or low pulse volume. And when do we consider it to be a large pulse volume? That is when the pulse pressure is greater than 60 millimeters of mercury, right? When the pulse pressure is more than 60 millimeters of mercury, this we call it as a large pulse volume. Right, this we call it as the large pulse volume. Okay, so normal pulse volume we tell when the pulse pressure is in between 30 and 60 millimeters of mercury, and when the pulse pressure is less than 30 we consider it to be a small pulse volume, and when the pulse pressure is more than 60 we consider this to be a large pulse volume. Now, so for assessment of the pulse volume you need to palpate the carotid artery. Next, now how to make out the character? So we have discussed rate, rhythm, volume. Then let me discuss about the character. See, the pulse character, it is best assessed in the carotid artery. By palpating the carotid artery, you will be able to make out the pulse character. And in the pulse character, you have the two important waves, right? So this will be your percussion wave, and this will be your dichrotic notch. So these are the two waves that you will have within the carotid artery, that is the percussion wave and as well as the dichrotic notch. Now let me discuss this will be the normal character. Now let me discuss the various abnormal characters of the pulse. So the first question is, Pulsus paradoxus is seen in all except intermittent positive pressure ventilation, chronic obstructive pulmonary disease, cardiac tamponade, and then the constrictive pericarditis. So Pulsus paradoxus, it is seen in all except you will have the Pulsus paradoxus characteristically in patients with the cardiac tamponade, right? That is a characteristic pulse. Now, first of all, let me discuss what you understand by the word the Pulsus paradoxus. Okay, so if you take in a normal individual, right, if you see in a normal person, the systolic blood pressure, it decreases. How much it decreases? It decreases by, right, it decreases by 10 millimeters of mercury during inspiration. That is what will happen in a normal individual. But what happens in the Pulsus paradoxus? In Pulsus paradoxus, right, the systolic blood pressure decreases, but it decreases more than 10 millimeters of mercury during inspiration. Right, in Pulsus paradoxus, the systolic blood pressure decreases. How much it decreases? It decreases more than 10 millimeters of mercury during inspiration. That is what is the abnormality in Pulsus paradoxus. So it is aggravation of a normal phenomenon. So Pulsus paradoxus, it is an aggravation of the normal phenomenon. Okay, so that is what is your Pulsus paradoxus. And this Pulsus paradoxus, because it is an aggravation of the normal phenomenon, it is also called pulsus normalis aggregans. Right, so this is also called pulsus normalis aggregans. That is what is your Pulsus paradoxus. That is another name of the Pulsus paradoxus. Now, you need to know what is why does this Pulsus paradoxus occur? In the sense, why there will be fall in the blood pressure more than 10 millimeters of mercury during inspiration. Okay, so for that you need to know what are the etiologies. One particular etiology of Pulsus paradoxus already I have discussed, that is the cardiac tamponade. Now, what happens in cardiac tamponade? Right, what happens in cardiac tamponade? Why there will be Pulsus paradoxus? Let me explain you. So, consider this to be a 4-chambered heart. Right, and surrounding the heart you have the pericardium, right, where you have the parietal and as well as the visceral pericardium, and within this pericardium you have the presence of the pericardial fluid. But in patients with cardiac tamponade, what will happen? The fluid which is accumulated within the pericardial space will be abrupt. So there will be abrupt accumulation of the fluid. Right, there will be abrupt accumulation of the fluid in the pericardial space. Now, because there is abrupt accumulation of the fluid in the pericardial space, what will happen? The heart, it is unable to relax. Right, heart is unable to relax. Okay, so thereby what will happen to your ventricular pressures? Ventricular pressure increases. Right, so because of abrupt accumulation of the fluid in the pericardial space, the pressure in the pericardial space increases. When pressure in the pericardial space increases, the ventricles, they are unable to relax. So thereby what will happen to your ventricular pressure? Ventricular pressure increases. So when ventricular pressure increases, the atria, they cannot empty the blood. Right, atria, they cannot empty the blood into the ventricle because the ventricular pressures itself, they are very high, and ventricle says to the atria, please don't send the blood. I am already under very high pressure, please don't send the blood. But your right atrium during inspiration, right atrium during inspiration, you know, there will be increase in the venous return during inspiration. So right atrium says that during inspiration, the blood from superior vena cava and inferior vena cava is entering into me. That is what the right atrium says. And because I am receiving the blood from superior vena cava and inferior vena cava, I don't have any other option except for sending the blood into you, that is into the right ventricle. And right ventricle says, please don't send the blood. I am under very high pressure because this fluid is accumulated in the pericardial space and the ventricles are unable to relax. I am unable to relax. So that is why don't send the blood. But right atria says, I cannot do anything. I am receiving the blood from the superior vena cava and inferior vena cava during inspiration, and I have only one option of sending the blood into you. So what will happen because of this? The pressure in the right ventricle abnormally increases during inspiration because of the inflow of the blood from right atrium to the right ventricle. So when the pressure in the right ventricle abnormally increases, you know what will happen? The interventricular septum, it gets bulged. Right, interventricular septum, it gets bulged into the left ventricle. Right, interventricular septum, it gets bulged into the left ventricle. So thereby what will happen to the LV volume during inspiration? Right, the LV volume decreases during inspiration. Right? What will happen to LV volume during inspiration? The LV volume decreases during inspiration. So, when the LV volume decreases, what will happen to cardiac output? The cardiac output also decreases. So, as the cardiac output decreases, the blood pressure also decreases. So, during inspiration, there is decrease in the blood pressure. How much is that? More than 10 millimeters of mercury. So, that is the reason why we call it as a Pulsus paradoxus. Okay, right. Now, this is the explanation. What is the mechanism for the development of Pulsus paradoxus in cardiac tamponade? This will be the mechanism. So, during inspiration, in patients with cardiac tamponade, the cardiac output will be reduced. Because the cardiac output is reduced, the blood pressure is reduced to more than 10 millimeters of mercury. Next, you need to know what exactly is a paradox here. The paradox is that the heart sounds are still heard on auscultation over the apex at a time when no pulse is palpable at the radial artery. So, what is the paradox here? The heart sounds they are being still heard on auscultation over the apex. In spite when there is no pulse being palpable over the radial artery. Okay, so that is what is your paradox. So, paradox is that the heart sounds are still heard on auscultation over the apex at a time when no pulse is palpable at the radial artery. So, why there is no pulse? Because during inspiration, the cardiac output is reduced. Right? During inspiration, the cardiac output is reduced. So, thereby what will happen to your systolic blood pressure? It reduces. So, thereby the individual will not feel pulse during inspiration even though there is presence of the heart sound. That is what is the paradox. Now, what are the other causes of Pulsus paradoxus? See, one important cause already I have said you, that is the cardiac tamponade. Right? So, cardiac tamponade is a condition where there is abrupt accumulation of the fluid in the pericardial space. And the other causes for Pulsus paradoxus is chronic constrictive pericarditis. Right, chronic constrictive pericarditis. Then the other conditions are severe COPD. Then in patients with hypovolemic shock. Right, in patients with the severe hypovolemic shock. Next, in patients with pregnancy, right, and in individuals with pulmonary embolism, then followed by that extreme obesity. Okay, so these are the causes for the Pulsus paradoxus. Very important condition is cardiac tamponade. The other causes include chronic constrictive pericarditis, emphysema, that is severe COPD, hypovolemic shock, pulmonary embolism, pregnancy, and as well as the extreme obesity. Now, and what exactly is the explanation of Pulsus paradoxus? The mechanism of Pulsus paradoxus, by taking the example of cardiac tamponade, already I have explained. And you have to know one clinical entity called reverse Pulsus paradoxus. Reverse pulsus paradoxus, it is seen in patients with the hypertrophic obstructive cardiomyopathy. This is a very important multiple choice question. So, going back to the question what we have seen initially, Pulsus paradoxus, it is seen in all except intermittent positive pressure ventilation, COPD, cardiac tamponade, constrictive pericarditis. Let me tell you, in patients on intermittent positive pressure ventilation, the Pulsus paradoxus will not be present. Whereas in COPD, cardiac tamponade and constrictive pericarditis, in all these clinical scenarios, you have the presence of the Pulsus paradoxus. Next question. Pulsus paradoxus is present in all, right? It is present in all except emphysema, pulmonary embolism, the hypovolemic shock, hypertrophic cardiomyopathy. So, in patients with hypertrophic cardiomyopathy, what you have is reverse pulsus paradoxus. Right, reverse pulsus paradoxus, it is seen in patients with the hypertrophic obstructive cardiomyopathy. Whereas, in all these conditions, you have the presence of the pulsus paradoxus. Next, the another important character of the pulse that we need to discuss is about the pulsus bisferiens. Pulsus bisferiens is best felt in the carotid artery, brachial artery, radial artery, and then the femoral artery. So, pulsus bisferiens, let me tell you, it is the one. Actually, what did I tell you regarding the character of the pulse? Character of the pulse, you will make out by palpating the carotid artery. But the pulsus bisferiens is that it is best felt in the radial artery, right? Radial artery. So, usually, right, you see here, usually the palpation of the peripheral arterial pulses such as radial artery, it gives less information regarding the character of the pulse then compared to that of the central pulse. What is central pulse? That is carotid artery pulsation. So, when you palpate the carotid artery, right, when you palpate the carotid artery, then you will be able to make out the character of the pulse easily, right, then compared to that of your radial artery. Whereas, in patients with the pulsus bisferiens, you need to examine the peripheral arteries, right. Certain findings such as the pulsus bisferiens of aortic regurgitation or pulsus alternans are more evident in case of the peripheral arteries rather than the central pulse. Okay, so that is about your the pulsus bisferiens. Where will you make out? Next question. A 78-year-old woman is admitted with heart failure. The underlying cause is determined to be hypertrophic cardiomyopathy. Which sign is most likely to be present? Dicrotic pulse, pulsus alternans, pulsus bigeminus, and bisferiens pulse. So let me tell you that in patients with hypertrophic cardiomyopathy, the pulse that you will have is the pulsus bigeminus. So in patients with hypertrophic cardiomyopathy, the characteristic pulse that you will have is the bisferiens pulse or pulsus bisferiens. So, what is pulsus bisferiens and what are all the clinical conditions where you will have pulsus bisferiens? Let me explain. Pulsus bisferiens is seen in all except aortic regurgitation plus aortic stenosis, aortic regurgitation, hypertrophic cardiomyopathy, and then the tetralogy of Fallot. Okay, so first let me discuss what is pulsus bisferiens and then let me come back to this question. So, if you take the bisferiens pulse, it is the condition which is characterized by two peaks during systole. Right, it is a condition which is characterized by two peaks in the systole, right. So, the pulse wave upstroke rises rapidly and forcibly producing the first systolic peak. Okay, so if you take the first first systolic peak, let me tell you, it rises rapidly and forcefully. That will be your percussion wave. And there will be a brief decline. So this will be a brief decline. And after a brief decline, right, a brief decline in pressure is followed by a smaller and somewhat slower rising positive pulse wave. Okay, so this will be the second systolic peak. Right, there will be a second systolic peak. Okay, so pulsus bisferiens, it is the characteristic pulse which is it is the pulse which is characterized by two peaks in systole, and that particular two peaks in the systole is better felt in the peripheral arteries rather than the central vessels. And you need to know what are the causes of the bisferiens pulse. You will have that in patients with pure aortic regurgitation, and you also have this in patients with combined aortic stenosis and severe aortic regurgitation. Right, combined aortic stenosis and severe aortic regurgitation. Then followed by that in patients with hypertrophic obstructive cardiomyopathy. Also you will have the pulsus bisferiens. These are all the conditions where you have the presence of the pulsus bisferiens. And you see this question, pulsus bisferiens is seen in all except aortic regurgitation and aortic stenosis, aortic regurgitation, hypertrophic cardiomyopathy, tetralogy of Fallot. So pulsus bisferiens, let me tell you, it is not seen in, right, it is not seen in the tetralogy of Fallot. Next, then followed by that, the another important abnormal character of the pulse is the dicrotic pulse. In case of dicrotic pulse, also you have the two peaks similar to that of your pulsus bisferiens. But in case of pulsus bisferiens, you have the two peaks in the systole. But whereas if you take dicrotic pulse, it also has two peaks. But here, in case of dicrotic pulse, one peak is in systole right, and the other peak it is in diastole. Right, one peak is in systole, the other peak, right, the other peak is in diastole. That is what is called the dicrotic pulse. And where do you have this dicrotic pulse? That is characteristically seen in patients with dilated cardiomyopathy. Right, seen in patients with dilated cardiomyopathy. Right, now after having discussed about the dicrotic pulse, the another important character of the pulse is the pulsus alternans. Pulsus alternans, it occurs in constrictive pericarditis, viral myocarditis, hypovolemia, myocardial infarction. So first of all, you need to understand what is pulsus alternans. Pulsus alternans, it is characterized by alternate strong and weak beat. Right, alternate strong and weak beat despite the regular rhythm. And this pulsus alternans, it is due to alteration in left ventricular contractile force. right? It is due to alteration in left ventricular contractile force. Okay, and where do you have this, right? Or what does it indicate? It usually indicates severe left ventricular functional impairment, right? Severe left ventricular functional impairment. Okay, next, what are the conditions where do you have this? The conditions where you will have this is in patients with toxic myocarditis, right? You will have this in patients with toxic myocarditis and in patients with acute myocardial infarction. In acute myocardial infarction, there is left ventricular function impairment. So, because there is severe left ventricular functional impairment, right? Because there is severe left ventricular function impairment, these individuals will develop the pulsus alternans. So, pulsus alternans is seen in patients with the myocardial infarction. So, you can see that here, this will be your pulsus alternans. So, you have one strong beat and then a weak beat. You have a strong beat, then a weak beat. Okay. So, this is what is your alternating small and large volume pulse. Right. Then another important abnormal character of the pulse is the pulsus bigeminus. Now, what do you mean by this pulsus bigeminus? Pulsus bigeminus is that where you have a normal beat, so this will be a normal beat. Right, this will be a normal beat and this will be a premature beat. Right, this will be a premature beat and followed by that there is a compensatory pause. Right, followed by that there is a compensatory pause. Okay, so pulsus bigeminus is that you have a normal beat followed by a premature beat and then a compensatory pause occurring in rapid succession. Normal beat, premature beat and then a compensatory pause. Normal beat, premature beat and then a compensatory pause. Okay, and in case of the pulse, see how do you differentiate in case from pulsus alternans? Because even in pulsus alternans also, right, even in pulsus alternans also you have a strong and a weak beat. Right, you have a strong and weak beat. But here in pulsus alternans, there is no compensatory pause. Compensatory pause is absent. Right, compensatory pause is absent. Whereas in pulsus bigeminus, you have the presence of the compensatory pause. Compensatory pause is present in pulsus bigeminus. Compensatory pause is absent in pulsus alternans. Then where do you have this pulsus bigeminus? Pulsus bigeminus, it is a sign of digitalis toxicity. Right, it is a sign of the digitalis toxicity. Right. So, now you see this question, yes, pulsus bisferiens, where is this best felt? In the radial artery. Now, you see a question on pulsus bigeminus. all of the following statements about pulsus bigeminus are true except it must be distinguished from pulsus alternans. It is a sign of the digitalis toxicity. Compensatory pause is absent. Rhythm is an irregular rhythm. So here the compensatory pause is absent is an incorrect statement. And pulsus alternans is a very important differential diagnosis. And in pulsus alternans, you don't have the compensatory pause. And this pulsus bigeminus, it is a sign of the digitalis toxicity. And compensatory pause is present, right? Compensatory pause is present in these patients with the pulsus bigeminus. And rhythm, it is definitely an irregular rhythm in pulsus bigeminus, right? So this is about the pulsus bigeminus. Next. The next important characteristic pulse is the water hammer pulse or the Corrigan's pulse. See, water hammer pulse or Corrigan's pulse, it is seen in patients with the aortic regurgitation. Right, it is seen in patients with the aortic regurgitation. And this water hammer pulse or Corrigan's pulse, it is a large bounding pulse associated with increased stroke volume of the left ventricle. Right, it is a large bounding pulse which is associated with increased stroke volume of the left ventricle. Okay, in aortic regurgitation, during the diastole, left ventricle will receive the blood from left atrium and as well as the regurgitant blood from the aorta. So at the end of the diastole in left ventricle, the volume of the blood will be increased. Left ventricular end diastolic volume is increased in case of aortic regurgitation. So subsequently, whenever the left ventricle contracts, the quantity of the blood which moves into the aorta will be very high. And that will give rise to a large bounding pulse. So a large bounding pulse associated with increased stroke volume of the left ventricle. And subsequently, there will be decrease in the peripheral resistance. Right, subsequently, there will be decrease in peripheral resistance leading to a wide pulse pressure. Right, leading to a wide pulse pressure. Okay, so in patients with the aortic regurgitation, whenever there is systole, a large quantity of the blood will enter into the aorta. But during diastole, the blood from the aorta will regurgitate back into the left ventricle. So thereby the diastolic blood pressure is reduced. So there will be fall in the diastolic blood pressure or there is decrease in the peripheral resistance, right? So the pulse strikes the palpating finger. So during the systole, right, the pulse strikes the palpating finger with a rapid forceful jerk, right, and then it quickly disappears. Right, and then it quickly disappears. And this water hammer pulse, let me tell you, it is best felt in the radial artery. Right, it is best felt in the radial artery. And the arm, whenever you are feeling for the water hammer pulse, the arm of the individual should be elevated. Right, the arm of the individual should be elevated. And where do you see this water hammer pulse? That is in patients with the aortic regurgitation. Right, now this water hammer pulse, this is also called collapsing pulse. Now why do you call this as the collapsing pulse? Why? Because whenever there is systole, there is a rapid upstroke. but during diastole there is a rapid downstroke, right? There is a rapid collapse, and that is the reason why it is called a collapsing pulse. Now, there are many other conditions where you have the collapsing pulse, not only seen in aortic regurgitation, but many other conditions. What are those conditions? That includes, the cardiac conditions include, I have a mnemonic. A PDA must be repaired. That is a mnemonic. The word A stands for the aortic regurgitation. The word P stands for the patent ductus arteriosus. The word D stands for the presence of defect within the interventricular septum, and that is the ventricular septal defect, large ventricular septal defect. PDA, A stands for aortopulmonary window. Right, aortopulmonary window. The M stands for mitral regurgitation, and that too a severe mitral regurgitation, right? And the word B stands for the block, that is a complete heart block, right? That is a complete heart block. And the word R stands for rupture of sinus of Valsalva, that is RSOV, ruptured sinus of Valsalva. Also, you have the presence of the collapsing pulse. Then, the other condition where you have the collapsing pulses in conditions like high cardiac output states, right? The mnemonic is ABCD. What does this ABCD stands for? A is your anemia, right? B stands for beriberi, right? C stands for cor pulmonale, right? And another C will be cirrhosis of liver, right? And D stands for a disease. And what is that particular disease? That is Paget's disease of bone. So these are all high cardiac output states where you have the presence of the collapsing pulse. And physiological conditions where you can have the collapsing pulses in patients with fever and as well as pregnancy. Okay, so these are all the causes for the collapsing pulse. Now the question is, this collapsing pulse, we call it as the water hammer pulse. Why do we call this as a water hammer pulse? See, it is termed after a 19th century Victorian toy, right? It is named, or it is termed after a 19th century Victorian toy, right? And that particular Victorian toy, is called the water hammer, right? And this particular Victorian toy, this is a peculiar toy where a sealed glass cylinder is half filled. You see this? This is a sealed glass cylinder, right, which is half filled, right? It is a sealed glass cylinder which is half filled with water, and half with vacuum, right? Half with water, half with vacuum. And remember, both the ends are closed, right? Two ends are being closed. And if the toy is suddenly placed upside down, right? If it is suddenly placed upside down, the column of the water strikes the other end of the cylinder with a blowing sound. Right? The column of the water strikes the other end of the cylinder with a blowing sound. And that is what is called as the water hammer, which is a Victorian toy. And even the pulse also, you have a rapid upstroke and then a rapid fall, which is a collapsing pulse, which is called water hammer pulse. And water hammer pulse is seen in, right? So where do you see this water hammer pulse? Aortic regurgitation, right? Now, you see one question regarding the pulse. All of the following clinical findings are seen in patients with isolated aortic stenosis except left ventricular impulse is displaced laterally in late stages. Pulsus bisferiens is the hallmark finding. Systemic blood pressure is normal in early stages of disease. Carotid thrill is present. Let me tell you, in patients with aortic stenosis, isolated aortic stenosis, the characteristic pulse is pulsus parvus et tardus. Right, pulsus parvus et tardus. That will be the characteristic pulse. What do you understand by the word pulsus parvus et tardus? It is a slow rising pulse delayed peaking or with late peaking. That is what is your pulsus parvus et tardus, seen in patients with isolated aortic stenosis. And left ventricular impulse is displaced laterally in the late stages. This is a true statement. Systolic blood pressure is normal in early stages. This is also a true statement. Carotid thrill is present. This is also a true statement. Okay. So this is about the pulsus parvus et tardus seen in patients with aortic stenosis. Now you see another question. All are associated with pulse being checked in the picture except dorsalis sign, early diastolic murmur, decreased LV and diastolic pressure, pulsus bisferiens. So the characteristic pulse that you are palpating, it is a collapsing pulse, right? It is a collapsing pulse. Where do you have that? In patients with aortic regurgitation. And in patients with aortic regurgitation, they have the dorsalis sign. They have early diastolic murmur. They can have pulsus bisferiens. But decreased LV and diastolic pressure is not the correct statement regarding the aortic regurgitation. In aortic regurgitation, there is increased LV and diastolic pressure. Right? There is increased LV and diastolic pressure. Okay. So this is about the pulse and their related questions. So in the pulse, what all you need to know? Rate, rhythm, volume, character, right? And all the abnormal characters you need to know. And you need to know what are the conditions where you have radio-radial delay and radio-femoral delay. Radio-radial delay, you can have that in patients with the Tachycardia arthritis. Right, you can have that in patients with Tachycardia arthritis. Whereas the conditions where you have the radio-femoral delay, radio-femoral delay, you will have that in patients with coarctation of aorta. Okay, so this is about the condition where you have the radio-femoral delay. So these are the important points regarding the arterial pulse. Thank you very much.